There is a difference between the ripening agent and the sterilizing agent. Ripening agent is ethylene. It's an alkene, 2 carbons attached by a double bond and 4 hydrogens. Whereas what you use for sterilization is ethylene oxide, C2H4O. So they are different materials, so you can't use one interchangeably. After the digression, technology is everywhere, and what I have been asked to speak on is the interface between e-technology and medical research. Whenever I am given unusual topics, the first thing I do is to look up what these terms mean, because I had no idea what e-technology really meant. And when I started looking for it, there is no clear definition that one can find. What I could come to close to it was, this term covers a diverse range of integrated communication and computer technologies, including software, storage, audiovisual systems, that is monitors, etc., so that one can store, transmit, access, and manipulate information for various purposes. And it covers everything from basic tools that we use on our cell phone every day to intermediate tools which need computer networks and very advanced data analysis systems. And medical research, we know, that is creative and systematic work to increase knowledge in the field of medicine and health, and that includes basic research, which is done in the lab, epidemiological research, where we look at relationships, causes of disease, outcomes, clinical research, applied research, and then also how to provide healthcare to people, and that's implementation research. So if we are going to look at not at medicine but at medical research, we really look at what are the steps in doing scientific research. We first need to think up a question and refine it. Once we have honed a question, we need to find a study design to answer that question and to develop a study plan. And then comes the meat, the real part, the implementation of research plan. And finally, from there we have our data, we analyze this and communicate research either as a presentation in a scientific conference or prepare a manuscript for transmitting these data as a publication. Each of these phases has become collaborative. At one time, there used to be an individual research or a group that used to do this. So today we have multicentric studies, collaboration. So really, that's first thing that e-technology allows us to do. Collaboration would just not be possible without e-technology. And so in each stage, e-technology plays a role. So I'm going to, it is so pervasive and there is so much that what you're going to hear from me are some areas that I have selected, because, the fact that we carry technology with us all the time, it's more inseparable from us than our even partner for life. So really, I don't think I can cover all aspects of technology. So spending a little bit of time on how to plan research, the initial steps, and writing and presenting research. In each of these steps, we need to do literature search, we need to access published literature and other information, we need to store data, we need to do analysis, we need to write and presentation, and I think everyone is familiar with various facets of technology that we use in this. We are familiar with PubMed, where we find literature, we are familiar with journal websites and accessing information from there. And there are several other databases. For instance, NCBI itself has several databases. And I'm not going to go into details of this because doing that itself would need a lot of time. For research, the other thing that one needs, in addition to information before one starts, is some skills. And these skills could be in the areas that one is familiar with. Say, everybody here is familiar with hematology, but there are several other skills that one needs in related fields of science, in some technology, some techniques, and there are a lot of courses available at different websites, and that's something, again, the way technology helps us to do research. And one thing that I'll particularly mention for residents are tools such as personal reference management software. So this is a screenshot of an area, as Anshul said, I work on a disease called hepatitis E. So this is a database using a software called EndNote that I have on my computer. So there are nearly 4,500 articles, as you can see on the left bottom. For each of these articles, it's a database. And for the articles for which I have a full PDF, You can see a clip mark here telling me that I have that article, and you can choose. I can search these for different things. I can divide them into those that are related to cell-mediated immunity. I can't see it from here, or whatever, different fields. I can look at for each article the citation. I can see the PDF. I can open this. So in a way, it's my mini PubMed and articles on my laptop. When I'm writing, when I'm doing anything, I can look up each of these things and I can use that. But I think what is more important today is how technology helps us do studies. So the first thing that one needs to do for doing a study is to identify subjects for a study, and we need reliable identification of each subject, particularly if we are in a situation such as ours, where there are parts of the country where people have multiple names. They could write their name, first name followed by the last name becoming an initial coming in the beginning, etc. Or names of persons and places are often repeated. So we have lots of Rampurs, we have lots of Bareilles, and village names definitely get repeated. So, and if you want to get people for repeated follow-up, it becomes important that you know that you identify each person reliably. So I'll take you to this trial in the field that I work in, a vaccine trial on hepatitis C vaccine, where in China they enrolled 112,000 subjects in a field study. Many villages, many districts. What do you do? So for each person, and they had to give them 3 injections at 0 month, 1 month, 6 months. They had multiple time points at which they collected specimens, and they followed them for a year every month to see whether they developed disease or not. So they used fingerprint scanners and digital photographs at each visit. It's a bit like our Aadhaar identification, and so that they were sure that the person that they were following up was exactly the same that they had started with, and that's a very important thing in research. And that's the kind of challenge we have in India. Our patients come, we see them, they go back, we never seem to get them back for follow-up. So this is what Mr. Nandan Nilekani, who is the architect of our Aadhaar system, wrote in the National Medical Journal of India about 7-8 years ago, how Aadhaar could be used for better health. And he identified these areas where Aadhaar could be useful. Clear identification of individuals, documentation from birth to death. So if a person came to you, enrolled in your study, and he goes somewhere else, and if we start using Aadhaar for health, we could know what happened to them in another hospital at a future time point. Better functioning of government-funded health programs. These are the items that he thought are related to health, and I've highlighted those that would be related to research. Sharing data among healthcare provider network. So if a person enrolls in a study here and then goes and enrolls in another study somewhere else, they would know that he's enrolled in a study in another institution. It could surely help us compile better data on disease prevalence, childhood and adult mortality, pharmaceutical use, and provide better health statistics. So I know there are privacy concerns, but once we are able to get over that, and I think the health sector really would gain a lot. If we could know who are the children who have received immunization against measles and who are the children who have not, if at every time a child receives a vaccine that could be recorded, we would really have a very important resource. That's not being thought of yet, but I think with programs like Mission Indradhanush and the upgraded Mission Indradhanush, I'm sure in a few years we would see that happening once the privacy concerns are taken care of. The second important thing in studies is to collect data. What do? We do field surveys, we do interviews, whether they're in the hospital setting or another setting. Then people come up every time, we have follow-up data. And for good studies, we need to collect follow-up data at multiple time points, which means patients need to come to us repeatedly. We need to send them reminders to take drugs, to come back for a procedure, to come for a follow-up visit. And there are times when subjects have queries and concerns, and if they want those answered, then they need to visit a health facility or the researcher. Now that's increasingly being done on cell phones, SMSs, internet, social media. I can tell you an interesting application I see in gastroenterology. We are interested whether the person had a yellow colored stool or a black colored stool. Is it melena? Earlier it meant asking them to keep a stool specimen, and by the time you came, the ward was full of smell. Today, all patients, they take a picture in the toilet of the stool, and we see that. Now, is that technology? Is that e-technology? I don't know. I leave the decision to you. But mobile phones can be used for collecting data, and this is a paper, not a recent one, actually 9 years old, where they actually used not smartphones, but the usual phones to collect data at each visit. You can collect data where a person has to choose one of several options, where more than one option has to be chosen and that could be true, or where you want some text information to be sent in. All this goes directly into a database or into a spreadsheet such as Excel and can be used. You can thank them. If you find a value which does not make sense, so if you're asking age and a person gives textual information or says the age is 130, you could remind them that those answers are not valid. So one can use reminders, one can use SMS, phones, apps, but there are more interesting things like drug adherence devices. And I'm going to show you something on which there was an editorial in New England Journal of Medicine earlier this year. So when you buy this drug, this is FDA approved, when you buy these tablets, you get the tablets, and along with that you get a patch that you can put on your skin, and you get an app for your cell phone. This tablet inside, if you open it, has a small 1 to 2 millimeter chip. It's a bimetallic chip. Once a person takes tablet, this chip is released in the stomach. When it comes in contact with fluids, with the gastric secretions, it gives out a signal which is picked up by the patch on a person's skin, and a message goes out to the cell phone, and the app sends out a message to all those whom you have added in the app. So somebody in the family could know that you have taken the tablet, so that if you have not done it by 12 noon, if they haven't got an SMS, they can call you back to say that you go ahead and take this, or maybe your doctor can do that, or at the very least, it goes into a database. Just think of this as an electronic system to monitor treatment. We have supervised ATT. This is an electronic supervision of ATT. If we could integrate this with our tuberculosis control program, it's going to be wonderful. And it's not that it is only a tool. People have done studies to show that when you give this to people who are diabetic, you can see with a conventional treatment, that was the decline in HbA1c, and when they were associated with these automated drug adherence monitoring devices, the HbA1c fell down markedly, much more, and the same thing when you give this use this for treatment of hypercholesterolemia. Data collection. A lot of data that we collect, radiology, pathology, nuclear medicine, ophthalmology, we do endoscopies, these are images. And computers are particularly good at handling images, acquiring, storing, transmitting them, and for pattern recognition. So we have something called digital pathology, also known as virtual microscopy. So what you have is a person sitting in front of a huge screen, not seeing images under a microscope, but on a huge screen. I'll give you an example from my field because I don't understand hematology as much, so it didn't really make sense my trying to explain that to you. What we are interested in patients with viral hepatitis and many other liver diseases is what's the stage of liver fibrosis. We classify this as F0, which is no fibrosis, F1, 2, 3, and F4, which is cirrhosis, and sometimes whether cirrhosis is present. The problem is there's a lot of inter-observer variability. Yes, it can be got rid of by training people, pathologists, but then there are very few trained pathologists available, and it will take many years before we are able to train people. So in this study that was published about 3 years ago, they took a slide. This was digitized using a scanner so that you had 0.5 micrometer to each dot, and these were scanned. Once these were scanned, automatically the computer took care of these small pieces of information that are here. It also looked at that this is a part of the liver capsule because it can detect that this is fat, so this has to be on the liver capsule. So this was removed. There are other areas where things are on the side, those are removed, and it takes that image. Now, because this is done using a red stain which stains fibrous tissue, if you use a green filter and obtain an image, you get an image of the red part, but now it is black. Then you can apply another filter that takes away the gray background and that takes away everything else, and what you have is an image only of the fibrous tissue. You can use computer algorithms to separate the fibrosis which is present in the portal areas and the septa, and fibrosis which is present around each sinusoid, the perisinusoidal fibrosis. You can from this image subtract this to get which are the areas, how the parenchymal areas are, so that you know whether they are nodules, etc. And you can look at where are the septae, and for each of these kind of fibrosis, you can give a different color. So that's the margin of the biopsy, which would be straight in a normal biopsy, which would be curvilinear in the case of fibrosis, in the case of cirrhosis. You can count the number of nodules, you can look at the size of nodules, you can see the distance between the nodule sizes, you can look at the portal fibrosis, which is shown in green, you can look at the fibrosis extending away from that, which is shown in red, and you can look at the perisinusoidal fibrosis, which is shown in black. So they looked at this and they looked at various parameters, and they found there were 6 parameters that, if combined, could diagnose on a biopsy very easily if cirrhosis was present. And also, if you're trying to look at F1 fibrosis, F2 fibrosis, F3 or F4, they found that there are certain kinds of fibrosis. If this is the one that is present, then you can diagnose F1, but if the others are not present, and when other things happen, then you can say F2, F3, F4. 5 parameters were very useful, and if you combine these were the cohorts they used to train the system, and look at the another cohort of biopsies that they used to diagnose. Area under curve of 0.955. Correctly classified biopsies, 87%. Something that even good pathologists are not able to achieve. Cirrhosis, even better, area under curve of 0.99 and correct classification of 97%. This is where pathology is. I have not shown you radiology. It is far ahead, and people are actually worried whether we should get people getting into diagnostic radiology, because possibly in a few years we are not going to need diagnostic radiologists. That's not the only place where we use imaging. Look at a tool to use to diagnose diabetic retinopathy. It's a tool where you go to a person, it automatically, you sit in front of a machine, it takes images of retina, automatically analyzes. So using a fundus camera, 2 images per eye are taken. These are automatically processed, and it tells you whether you have more than mild diabetic retinopathy. If that is the case, it sends you to the ophthalmologist, gives you an appointment. If you don't have it, it tells you to go back and come back in 2 years. Good images could be obtained in 96%, sensitivity of diagnosis was 87%, specificity was 90%. So all of us who really look at images need to be worried where technology is going to take us. And now this is something that happened to me 3 days ago, when for a colleague's son who has got admission into a residency program and they had a small dinner party, I wanted to buy a gift. I thought I would buy him this book, When Breath Becomes Air by Paul Kalanithi, because that's a book on medical subject that I thought he should learn how to take care of terminal patients. The moment I opened Amazon, it said I had already bought this book on 16th of December 2016. That was for myself. Warned me, be careful, you already have it. And then it told me that look, all the people who buy this book also bought these other books. Think, if a patient comes to you, you make a diagnosis and you prescribe a treatment. By pattern recognition, that's what Amazon does, that's what Flipkart does. It told you all the people who got this drug 4 years ago, 10% of them were diagnosed to have disease Y 3 years later. And you could decide whether to use that drug or not. Don't be amazed if you see this in a few years. I had my moment of amazement when I visited my daughter in July. You go into an Amazon Go store, you walk in, all you need is an app on your phone. You just put your phone next to the machine at the entrance, go in, you pick up a cake, it bills it to your phone, you put it back, it returns the money back. You go into a store, there is no checkout, there is no check-in, and it automatically picks up. There are so many cameras that pick up what you pick up, and it doesn't seem to make a mistake. So that's going to happen in medicine. So we have these data sources. We have people from whom we are claiming reimbursement, we have pharmacies who are supplying drugs, we have patient-doctor encounters from where data go into databases, we have labs, we have devices. We have devices like our wearables, where our heart rate is being monitored, where our pulse, where how much we exercise is being monitored. We have data from hospitals, data from clinical trials, we have genetics. And I've not gone into things that you hematologists use genetic data and expression data, because I think that you know. Now, each of these has been used for years to do medical research. We know of studies from Scandinavia where they follow large cohorts of people, link it to mortality data and find out how people live with a particular disease. We have databases of people who receive certain drugs, and we know who goes on to develop adverse events. But so all this is going to happen, and artificial intelligence is going to be in, and we'll hear more about it. Technology can help us to do randomized trials, and this is an interesting paper that was published about 5 years ago. We have people who visit us with hyperlipidemia. We enroll them into big trials, give them something, one drug versus the other drug, follow them and see what happens to them. In this trial, people who are attending a general clinic, it asks a physician, when at the end of the physician encounter, do you think he could receive either this or drug A or drug B for hyperlipidemia? And if the physician said yes, the decision on which drug to give was made randomly by the software rather than by the physician. These patients were anyway being followed up. At the end of 2 years, they had results of comparison of drug A and B in the treatment of hyperlipidemia without doing a costly trial. So that's going to happen. Finally, this is what my cell phone told me when I walked from my home here to this auditorium here, how I have walked. Even if you cross the road, it can pick up. It can pick up your location everywhere. And if I try to look at where I was on 16th of October, it told me I took a flight from Delhi. It picked up that I had been at the airport in Dubai, and then I had picked up a flight to Geneva. The next day that I had stayed in this particular hotel, I had walked to the WHO headquarters and back. I've shown you only 2 days. For each day, Google knows where I have been. So this GIS information is being used. This is the Ebola outbreak in Africa. It tells you on a particular day cases that have recovered, cases that are still there or are being investigated. The size of the circle tells you the number of cases at each location. What a fantastic way to monitor an outbreak. You know that disease is disappearing in this part and disease is now appearing in this part. I'll let you guess what this represents. Anybody? Sorry? Air traffic over 24 hours as the day and night, as you see the. So if you have SARS today, you can model, knowing where the outbreak is, how many flights arise from each place, and say where could you expect it next to be. Anybody can tell me what this is? What is that red area? So this is, so you can use GIS data to predict health problems. You can say what is related to money, what is related to economic status standard. So this is, as you rightly said, the Korean Peninsula, a surrogate marker for economic prosperity, amount of light that that country has as picked up by the satellite at night. You see the South Korea, this is Japan, and that's North Korea. Except for Pyongyang, you can't see anything. Now, if you can do that for different parts of India and see where, what is, and how diseases occur, that's going to be useful. And finally, a small illustration of what is going to come. This is something published in Science earlier this year. They made an ingestible bacterial electronic system. So what they have is a capsule. We use this for endoscopy already, these capsules. So this capsule has these chambers where there are recombinant bacteria, which, if they come in contact with heme, emit light of a particular wavelength, and that's picked up by the sensor. So you swallow this, and as it goes through, anywhere it encounters blood, it would start giving out a signal, and that signal can be picked up on the skin. For now, what has been done are pig studies. So they took pigs, they gave them, they placed some blood in their stomach, and maybe I didn't show you in the previous slide. Okay, let me just go back. And if you, sorry, I don't have that here. The sensitivity is of the order of 10 parts per million. And if you place small amount of blood and then you give this, you can see within 30 minutes you start seeing a signal compared to if there is no blood. Now, blood is easy to detect. We can do fecal occult blood. But this can tell you whether this is in a particular location. And that's only the start. They've developed similar sensors for other biomarkers. One of those is thiosulfate, which in animal studies have to be found to be increased in tissues where there is inflammation. So you could do that. They've done this for acyl homoserine lactone, which is produced only by certain kinds of gut microbiota, so you can monitor microbiota, and they are on to develop this for many other metabolites in the human body, and we would be able to detect what is where. Maybe we'll put it into, we'll miniaturize it so much that it will go in the blood, it will go in circulation, and it will also tell us which part of the body the signal is coming from and where that metabolite is. So friends, technology is changing the way we do everything. From communication, it's changed how we communicate, it's changed how we date, it's changed how we move around. So it will be no surprise if it changes the way we practice medicine and do medical research. In general, it appears to me that compared to other fields of life, the effect of technology on medical research should be good, because it will make conduct of research easier and the findings more reliable and robust. Yes, it's going to be costly, and if we wish to remain abreast with the rest of the world in biomedical and health research, we must embrace technology. Thank you.